So welcome to the next session. We've already seen some great cases this afternoon with left main angioplasty, bifurcation angioplasty, some good, interesting results. So now we're going to have a combination of live cases and lectures from Fuwai Hospital. And the first case is going to be from Yongjian Wu. I don't know if they're ready for us yet. If they're not ready for a minute, we'll just introduce the panelists. Obviously, S.J. Park is co-moderating this with me. And we have Dr. Aramsareewong, Dr. Ashida, Dr. Choi, Dr. Kwok, Dr. Kwon, Dr. Lam, Dr. Ban Lao, Dr. Nam, and Dr. Wojciechowski. So, shall we hear from Fuwai?
Right. Hi. Can you hear me?
Yeah.
Dr.
Perfect
Wu.
Park. So here it's clear.
All right. Thank you for joining us. All right.
Yeah,
really,
thank
all
you.
right.
Thank you very much, Perfect Park. And thank you very much for inviting us to join this very important event every year. So I'm Dr. Wu. So dear chairman and panelists. So we're very happy to have this case in this afternoon. And originally, several weeks ago, we submit another case. So that case is the PCI after the TAVR. But unfortunately, just 2 days ago, so that patient had COVID-19 again. So we cast that case. So this afternoon we change another case. This is the classified lesions. And maybe the first I introduced my team, so Professor Zhang Hongliang and Professor Zhang, and also technician, the Mr. Seung-Jung. The first I let the Professor Zhang Hongliang to introduce briefly about this case.
Yeah, okay. Dear Chairman, dear colleagues, and all the experts, first let me introduce the...
We cannot clearly hear you.
You're not clear?
Yes.
Okay, so moment please. So we just change.
Okay, getting better.
We change my microphone.
I'm sorry, is it clear now?
That's better.
Okay, yeah, good.
Yeah. This patient is 68 years old gentleman. He had exertional angina for about 6 months. For the last 1 month, the angina aggravated mostly. So 2 weeks ago, he had coronary angiography in the local hospital and found severe stenotic and calcification lesions in LED. The local hospital cannot do the complex PCI, so the patient transferred to our hospital. The patient had no myocardial infarction, had no PCI or cabbage in the past. Next. The patient had following cardiovascular risk, include hypertension for 15 years and smoking for about 30 years. The clinical indication for PCI is unstable angina. Next. The laboratory test showed that from the echocardiography showed normal left ventricle chamber dimension, and left ventricle ejection fraction is 62%, and the ECG showed ST segment depression in V3 to V6 lead. The laboratory examination showed LDLC is 1.97 millimole per liter. The NT-proBNP is normal. Then let's see the coronary angiography.
So here is the coronary angiography. So it's clear. So now switch to the screen.
Yeah, please.
Okay, good.
Thank you.
So Dr. Zhang continue.
Yeah. From the angiography, we can see severe calcification in LAD in the proximal and middle segment. Also, we can see a severe stenosis in the proximal part of LAD. Also, this patient had a very big first diagnosis. And we can see the middle part of the left circumflex is occluded. But from the collateral circulation, we can see the segment beyond the occlusion is not big. For the right coronary artery, there is a borderline stenosis after the first curve.
Okay, stop. So maybe next. So now we stop here. So I think it's not very difficult, the case, but the features are the calcified, the long lesion, and also bifurcation. The cardiac function is relatively normal. And according to our experiments, so the calcification is moderate to severe. So from this slide, so we can see, so the Y is the...
Just a minute. Okay, Dr. Wu, we cannot see you. We have some technical...
no, nice signal is not good. 我们看一下这个信号不是特别好。稍等。So Professor Park, do you hear me?
Right, so I can hear you. However, we
Yeah,
cannot see
I can hear you.
I
can see you, but here maybe the signal is not good.
I'm sorry that.
Sorry, doctor.
Yeah, maybe now we can start to discuss. So I don't know. So next week we'll discuss the strategies.
Yes,
So because maybe the takes several seconds, and we're waiting for the signal. So maybe we stop the computer. So Professor Park. So
whilst you're sorting out the signal,
so please wait several seconds.
That's fine. We'll have a discussion on the panel about what people would consider here. So any comments so far about what people's strategy might be with this intervention?
Firstly, I agree that we should touch the LAD first. As you can see, the flow in LAD was already limited. It's not normal flow. And we see the LAD was heavily calcified. So it's very, very heavy, even from the angiogram. So you must think about some strategy to deal with the calcium. Rotabation would be the first choice. The only argument is what is the size of the bird that you may choose in this case.
So would you consider just a small balloon dilatation so that you can get the IVUS in and see a little bit more, or what would anybody's strategy be for the first up? Because as you rightly said, there's very little flow in the LAD. Maybe an IVUS catheter won't pass. Will you do a pre-dilatation first?
I think I will use a small balloon to dilate because the tight lesion we could not pass the IVUS in, and after that consider do we need to do the rotator or not, and we have to consider about the guiding sheet what guiding sheet that we use and prepare the number of the rotator.
Sure. If they gone radial or are they femoral? Because in Europe we're stuck with 6 French. If we're in the radial, they don't like it any bigger than that. Would you do 7 French from the radial?
It's quite common to do. We have a 7-in-6 shift,
Yes.
so we always prepare with 7-in-6. So we can always go with 7 fans.
Okay. And who would be looking at rotablation and who would be looking at shockwave or some other therapy?
Okay, so that this patient, I don't know the patient, old age. So, but ejection fraction is good. So rotablate is one option. And another option is IVL shockwave, and maybe lesion length is 40 or 45 from angiography, I think. So two shockwave balloon is effective for this case, I think.
Yes.
But shockwave cannot cross the lesion. So small balloon or rotablate is mandatory before using IVL, I think.
Yeah.
So probably there are two.
Rotor shock
Yes.
situation.
Yeah.
And if you look carefully, the osteodiagonal is also diseased. So after rotablator, probably wire the diagonal and then do shockwave and balloon the diagonal and do a probably professional standing across the D1 LED bifurcation.
So there are two types of calcification. First, proximal is subocclusive, is heavily calcified, so it may be difficult to deliver the shockwave downstream. But the next part, the mid LAD, it's very calcified, and this calcium layer is very, it's probably the full size of the vessel wall. So probably combination of two may be needed because rotablation will not ablate this thick calcium in the mid part.
Yes.
Chairman and the
ready.
panelists.
Dr. Wu, we
We
can
come
clearly
back.
see you.
I'm
All
sorry.
right.
Yeah,
Okay.
because the signal
Okay,
is
you can
stopped.
proceed.
Yeah.
You proceed,
So we
all
come
right.
back. So I'm sorry. So just now I hear the discussion from the panelists. I think
Good.
all the panelists and the friends and take a lot for suggestions. So from the coronary angiography, so we think this the calcification. If we treat this the calcified lesion, because this the curved, it's the maybe we the first we use the ablation, and maybe we also use the shockwave, and so from the last the back last color, yeah. From next. From this view, next. From this view, because the Y is a change, is the morphology, so we think this the curve. So maybe it's difficult for the stint, and now you after the wiring, so the blood flow become the slow. So we use the small balloon and to dilate the very severe segment, and then we check with the OCT. So next, and let Mr. Sun and to show us the OCT finding. Mr. Sun, please.
Great.
Yes, please.
Image, right?
Let's show the OCT. Please show the OCT image.
Okay. A moment, please.
Okay. So this is a pullback from the middle LED. We can see this is the distal. We can see the reference is about 2.75, and there's no calcification. And here we can see some small calcification. The lumen is okay. This place is the stenosis after the second diagonal. So we can see more calcification here. And this is a big vessel. And here, we come to this part. This part, we can see severe calcification, circular calcification at this part.
Yeah, circular.
And also, it's also near to the ostium of the first diagonal. So this is the proximal LED. Yeah. And from 11 o'clock, we can see the second flex. And we put a Godzilla in the left man. So this is the end of the OCT. So we make some measurements. And we can see the distal reference of the vessel is 2.75. And also we can see there's a severe calcification. We also make the measurement of the depth of the calcification. It's more than 1 millimeter. And the length of the calcification is about 20 millimeter. So this
Okay.
is OCT results.
Okay, thank you, Mr. Seung. So, and now, so maybe we can open the discussion about our strategy. So, because before in the last years, and in China, we have no shockwave, just from the last year. So the shockwave available commercially in China. So now we have the many solutions for the calcified lesions. And for this lesion, maybe the first we use the ablation, and we freed the shockwave balloon. It's very difficult to move forward. But here we show all the panelists next, and we will test and whether or not the shockwave is easy or not to move forward. So this is the balloon. This is the regular balloon. So from this slide, we find so this balloon is not very difficult. So and originally we want to use the ablation first, but now I'm afraid. So for the shockwave, because we have very few experiments about shockwave, we are not sure because this is a regular balloon. We are not sure the shockwave is easy or not to move forward. Yeah. So and I really hope the panelists give us suggestions.
Yeah. How about the panel? I think someone had suggested to use shortwave before. From the OCT finding, we found that there's circumferential calcium, so likely shortwave will work in this case. However, we see the calcium is very long. The shortwave just have X cycle, so you need to invest very carefully and wisely for the X cycle. So in this sort of sense, I don't know what about the others thinking. Will you still consider water ablation first and then use the shortwave wisely, focusedly over the most heavy calcified area so that you get a perfect result? Because after all, this is LAD. So you want the patient have less MACE and CABG equivalent. How about the others thinking?
Yeah, actually, I fully agree with what Dr. Ho mentioned. In my own experience with IVL, it's very bulky, and I think this is a point that many of the other panelists have brought up. I don't think a smooth passage of a compliant balloon should be taken for granted that the IVL go in easily. And then sometimes you have the dilemma of going in with an NC balloon and going at high pressures, creating dissections, and then having some sort of regret that you didn't do rota early on. So my personal preference is, like Dr. Ho, I would still strongly consider rota.
Okay. Any other thoughts?
Okay.
Yes.
So maybe the most calcification site is a fully circumferential type, and the most sequence is a 1.03 millimeter. Maybe lacrosse NSC balloon, scaling balloon does effect in such situation. The one option is using lacrosse NSC balloon with leopard corner technique is one option. If NSC balloon does not work, we change the IVL, one option.
So what size predilation balloon do you use? 2.0?
Yeah,
just now. 2.0?
Yeah, 2.0 NC balloon.
2.0 non-compliant?
Yeah, it's totally open.
Yeah, I think you can go straight to shortwave.
Yeah.
Okay, thank you.
I think so too, actually. Yeah.
But from the OCT finding, so this the calcium certification is circular, and also it's very thick, and it's more than 1 millimeter. And when we handle the wine, so wine is very smoothly to the distal. And sometimes if we when we handle the wine, it's very difficult. It's the guard. So when you move forward wine, so the guarding catheter is back. So I think maybe we should use the rotablation first, and then followed by the shock wave. So here we would like to try the shock wave first, and if that doesn't work, so maybe we can switch to the rotablation, because here we also use the Godzilla. So I think we can move forward the shock wave. So Dr. Zhang, please. So let us say.
Okay, hands up in the audience who thinks the shock wave is going to pass.
And what is the size of the shock wave?
Okay, that's very good. Thank you for playing. And hands up everyone who thinks it won't pass. Okay, now that means 90% of you aren't awake.
Also, for this case, you need to have a shock wave larger than the minimum size of 2.5, because this is the larger vessel. So, but I keep the fingers crossed for them to pass.
What is your choice? Which size of shock wave you use?
Yeah, so it's according to the OCT. So maybe we select 3.0, the shock wave blown. Yeah.
Yeah, I also want to share my experience on shortwave. It's okay. I think most of the time we can deliver the unused shortwave. In this situation, you can deliver to your target. But once you use the shortwave, once it was used, the used shortwave, you want to re-deliver it is very difficult. That means while you want to adjust the position inside,
so it's very easy to cross.
Very nice.
Yeah, very. So now the shockwave start work.
Okay, so you're up at 4 atmospheres, are you?
Okay, so seems to be good. So it's totally open.
Now we face one issue. This for the shortwave is recommended on the same side. You at least to have used 2 cycles. So now you have to use 2 cycles over here, and then
look. After first use,
the shortwave is very expensive. You will not be able to cover the whole length.
Yeah. But as you say, you can use it wisely and come back 5 millimeters, take another 10 pulses, come back another 5. That changes the area where you mosaicize the calcium.
Just for the audience who are new to the shock wave, if you pay attention to EKG, we would notice the shock topic, which is rather common with capture of the ventricle while you are doing shock wave. But there is a rare case report of ventricular fibrillation while your shock is delivered on the T wave. So pay attention to the EKG.
How many pulses are you using at each location?
3 to 4. So this is the 4th. This is the 4th. So now it's the 6th atmosphere.
For the shockwave, you also need to focus on the shockwave balloon. The 2 radiopaque marker is not the effective area of the shockwave. The most effective area is the 2 semi-opaque marker in between the central part. And usually, while I use shortwave, I always use stent boost, because at this moment, OCT IFS can't help you. However, in this moment, if you use stent boost, you can clearly identify where is the most calcified part, so that you can use your shortwave wisely.
And here in this bit, you can see the wire bias means that most of the dilatation is actually away from that large bridge of calcification.
Okay, this is the 4th. It's the 5th time. Okay, so now this is not the severest notice segment. So
I guess at this moment we have used X cycle already.
Yes, I was going to say how much is left.
It's the 2 times left. So this is 6.
There's 3 times.
It's the 3.
Okay.
Oh yeah, so back a little bit. Back a little bit.
Okay.
Yeah, back a little bit. Okay, good.
We haven't asked the operators' experience. How will you choose the size of the shortwave? Do you have any experience to share with us?
Yeah, so we have very limited experiments, but that's according to the clinical trial. And normally 1:1 the size. So in this case, we select 3.0. But it's in the middle, the RAD is the 2.9, but in the proximal, very proximal, is the 3.2. Yeah, so finally we select the 3.0. Okay.
We have finished 6 cycles lethal angioplasty, and there are 2 cycles left.
So, and Chairman and the panelists, so shall we continue another cycles?
For educational sake, could you try to use the shortwave again into the AD, down to the mid-AD? Could you just try this to demonstrate?
Okay.
Yeah.
Now, you see, once the shortwave was used, it's very difficult to adjust the positions anymore. So you need to be very careful. Make sure while it's in the new shortwave, you have to push to the target. Once it open, it's very difficult to push again.
Mm-hmm. Okay, good. Hola.
We had tried the method of rewrap or many other way, but no use. It's very difficult to reuse the shortwave balloon. Mm-hmm. The best way, in my experience, is still the guide extension. You use NC balloon, track the guide extension down, and then you may be able to deliver use the shortwave.
Yeah, we can see.
Nice.
Yes. Okay.
It's here. Here. There's 1 cycle left.
It's the last cycle.
Are you saying that you use the guideliner routinely with the shockwave? Do you use it routinely?
No, not in routine. But for deliver we use the shortwave. Sometimes could be very challenging.
Yeah.
Okay, we have finished 8 cycle shockwave angioplasty.
Nice. So will you now use the same balloon to higher pressure without the shockwave?
Is the regular balloon or the not shock balloon?
Yeah.
It's the non-complaint balloon. Mm-hmm. So now we would like to use the OCT to check it again.
Okay, great.
Okay.
We'd like to see that. What's happened? Oh, these walks.
But reuse shockwave balloon run the risk of balloon rupture. If you cross the speckled calcification again, it may cause pinhole rupture. If the balloon rupture during the shockwave, it would be disastrous. We've seen many cases of unzipping the whole vessel because the shockwave energy is very strong.
Yeah.
But after you've delivered all the cycles, you can use the balloon without the cycling, can't you? Without the shockwave component, if you want to.
But the balloon is very fragile and very winged, as you can predict, right? But you reuse it for another shot is pretty risky.
Sure.
Yeah.
If you use OCT as P-imaging, if you have co-registration, sometimes it's good because you can exactly localize where is the most calcified area. If you don't use stent boost, then co-registration by OCT is another way to localize the calcified area and then do your shockwave.
Okay, from here.
Okay.
Okay, good. So let us see.
Ready?
Ready?
Okay.
Okay, now Mr. Sun to tell us.
So this is the OCT feedback. We can see the distal catheter is not stable, and it's in the middle part. We can see some section, and we are approached to the proximal LED, and we can see this is the most severe part of the calcification, and we also can see some cracks here.
Right?
So I think this is the result of the shock wave.
Yeah. Okay.
This is proximal of LED.
Yeah, how about the results? The panelists can tell me.
Great.
Any comments?
Great results. We see particularly the area with circumferential calcium. You can see cracking over there.
Wow,
and this
great.
case is very educational.
The first time.
And it well
It's the first time, right? Oh, great.
Impressive.
Yes. It well demonstrated. Even the thickness is more than 1 mm is okay.
9 o'clock, 7 o'clock. All right, here we are.
Yeah.
Oh, enlarged the woman. All right, great.
Impressive.
Okay. Yeah. Okay, so now we stent there. Okay, stent, please.
So you tempted to do any non-compliant balloon therapy now? Did I hear you say stent?
So maybe we can. So also we can use the non-compliant stent, the blown to dilate again. And but I think we use the Godzilla, so it's easy to deliver the stent to the distal. Yeah. So the first we use the stent after staging. It depends on the stent performance. Maybe we use the non-compliant blown to make the post dilation. Okay.
For most people on the panel, do they mostly go at this point, having seen those images, straight to stenting, or maybe balloon first?
I think always balloon, because you need to spread the cracked calcium, and sometimes even small bump of calcium can stop your stent from advancing.
Yes.
So
I agree. But from the OCT finding, we will hope the smoothly, because we use the Godzilla.
So what length and size stent have you chosen?
Yeah. Okay, let me see the stent delivery.
I have no ideas. Is there any limitations of some breakdown, the calcium, the thickness concerns, calcium thickness? I have no ideas.
Yeah, no, I mean, I'm no expert either.
right.
We've only just, had access to this technology in the UK.
What about the thickness is more than some 5 millimeter or something? It works still?
Yeah, it still works, provided that is concentric. It's not eccentric, concentric calcium. Even very thick is also great. I do not have the exact figure, or I cannot say about the upper limit, but so far all the case, provided that is concentric calcium. So always okay so far. But eccentric is another story. For eccentric calcium, most of the time do not work.
Especially calcified nodule is another animal. Even with the short wave, sometimes you can't shape or crack the calcium because the dissipation of energy is different.
Yeah.
不要了是吧？
我想不要了，直接上指甲，不想用嘎机了。
Is there any
because the first stent stacked in the
Korea,
in the
IVL is
Godzilla.
not available now, so only
Yes.
we have three options
Yeah.
for region preparation. First one is high pressure balloon.
Yeah.
Second one is current balloon or scoring balloon, and third one is rotablation.
Okay.
Anyway, actually, I first real live show.
Experience.
Yes, OCT finding after IVL.
Yeah.
Looks like very fantastic, and
Yes.
lumen widely open, and there are many claques. So actually, the stent expansion is related to how many claque was made.
Yes.
So looks like widely open lumen and claque was there.
Yeah.
Multiple claque was there. So I think direct stenting
be
maybe
good.
can
Yeah.
be expanded very
Oh,
well.
Yeah, I was surprised how extensive the cracking was, because I mean I'd understood that
Yeah,
you get
burst
more
mostly.
micro cracks rather than sort of breaking the windscreen, that you sort of cause it to shatter. So you get lots of minor cuts rather than that very deep cut that we saw there. So I was quite surprised by the OCT appearance. Does anybody want to comment on that? Yeah. Yeah. Yeah.
You mean for efficacy of shortwave?
Huh?
You mean the efficacy of shortwave?
Yes, yes. You're not expecting really the same sort of tectonic plate movement that we saw there, more micro fracturing.
So the fully circumferential position, at least 2 cracks is important. However, after using IVL, major crack and micro crack is occurred. So easy expanding this.
I must. I don't know if my experience is enough to comment this or not. I probably used around more than 350 shortwave before.
Oh, that'll do.
In my experience, I found don't expect too much, especially on essential calcium. After several hundred shortwave, nowadays my practice always change to water short. I will still prefer to use water first, because I found that many of the time it cannot clear the calcium very effectively. Okay. You still need something more. Just shortwave is not enough.
Yeah.
And sometimes not common, but sometimes after shortwave, you will find that the calcium just protruding out, and then it's very difficult to deliver even a balloon after the shortwave. So it's always safe to do a water first and then deliver the shortwave. Okay. But this is my limited experience.
Oh no, that's quite a lot, 350. It's going to take most of us a long time to catch up.
So you did non-compliant balloon inflation?
I think so.
Right.
What was the balloon there?
Could you explain that?
Yeah.
What you've done?
So we find, so after shock wave, so the stent is very easily to be delivered.
Yes.
Yeah, so very good.
So they already performed the mid-area stenting, and we are too much focused on the calcium today. But in this case, the proximal part of RAD looks bifurcation, right? So yeah, even though it looks 0-1-1 region, anyway, it includes calcification, so it will be better to wire protection. So I would like to recommend that wire protection, but you already select, yeah.
Yes. Arthur. Okay.
So now this is a balloon?
Oh, that's, yeah, no, not the second stage in the very proximal, the 2-3/18. And we also use the nut balloon to gel the first diagonal. Okay. Yeah. Okay. Hold on. Hold on view. So I think the stance, the position should be in the very proximal RAD. Yeah, good. Okay, good. So the balloon in the moment, please. So the balloon in the diagonal, the back. Okay, good. Let's start. Yeah. Yeah, this is the 3/18.
Okay.
Okay. Down. Okay. So, and finally, we will check with the OCT. Zhongwei. So, okay, good. So now OCT again.
Still 410. 410 still.
Yeah.
Yeah.
And so sometimes for the calcified lesions, and sometimes we, the calcified is not very severe, but the procedure is very difficult. But sometimes it looks very severe calcification, but it's not very difficult. Yeah. So I think it's the iris and the OCT is very useful to guide the Okay, good. I'll stop here. Yeah. Let me test.
Sorry. Okay, please again.
Test again. Ready? A moment, please.
I think this small point so that the operator is very skillful. You just use a usual syringe and they can make the OCT image very clear.
Push.
Okay.
Oh,
Yeah.
It's very strong.
Yeah, very strong.
Very skillful OCT operator.
Yes.
Yeah, we can see the stand is well posed.
Still on the expansion. Malar position is kind of weird.
Yeah.
Well approached to the most classification part. Well posed. Stand is circular.
Yeah.
And this is already to the proximal LVD.
Okay. So finally, maybe we use the non-couplant balloon to make oscillation. Is it necessary or not? So tell me and the panelist. So you want to make, it's necessary to make a oscillation?
Definitely.
Yes, I think so, yeah.
Yeah. So 我们用一个 3.0的后扩张器拿来。来。
I think the advantage of rotor shock versus balloon shock is that if the rollerblader can actually shave and polish the lumen, and your shockwave balloon will oppose better to the vessel wall, and you can dissipate the shockwave energy more evenly. So I still think that at the outset, if we didn't pre-dilate, I would probably go for rotor shock in this case.
Mm-hmm. Another consideration is reversibility. As you can see from the first image, first OCT image after the shockwave, you can see there are multiple dissections. After that, of course, you can still go for rotor ablation, but it will be more risky. Yes. However, if you do rotor first, you can always go to the shockwave, but not vice versa.
Yes.
So is your sizing for the post-dilation balloon based on the, not media to media, but your sizing based on the lumen diameter, right?
Okay, okay. The 20, 22. Okay, good.
Okay. What size of balloon do you use for the?
Yeah, the 3.0, because the distal, in the middle segment is 2.75. Yeah. Okay. Finish short. So take the final angiograph. Okay. Yeah.
Great.
Yeah. The caudal view.
Look good.
Mm-hmm.
Okay, so this is our final result.
Very nice.
Great.
Yeah.
Excellent.
Thank you. Okay, thank you. Thank you again for invitation. Okay.
Thank you very much, Dr. Wu, Dr. Zhang. We're going to go to the other lab then now. So thank you. If we don't see you later, thank you ever so much for joining us for that great case.
Yeah.
All right, Dr. Do, Dr. In, can you hear me?
Yeah. Can you hear us?
Okay, so you're on the screen, and so you're gonna start your cases.
Okay. Good afternoon, dear colleagues and friends. It's a great honor for me to be invited to do a live case for TCTAP 2023. I'm Dr. Do, and my right side is Dr. Yindong. He will help me today. And I also have Dr. Chen and Dr. Yan, our fellow, here to help us. And first, Dr. Yindong will introduce the case.
Good afternoon. He is a 54-year-old gentleman. He suffered stable angina for 8 years and exacerbated for 1 month. 2 weeks ago, he underwent coronary angiography at a local hospital, which shows 3 vessel disease and CTO lesions in circumflex and RCA. The patient denied previously myocardial infarction and previous PCR and cabbage. Next. 下一张. And his risk factors include hyperlipidemia and smoking. Next. The UCG showed the normal left ventricle size and function. And this is the angiographic. We can see there's still a severe disease in the distal LAD, and the RCA and the circumflex both occluded. We also perform CTA before this PCR. Next. We can see the the length of RCA is wrong, and there are some calcification within the CTO. So the JCTO score about 3 points. Our first target region is RCA. Next. And we will start from the integrated wire escalation, and the backup plan is retrograde PCR from the septal collaterals. That's all.
Okay, nice.
Okay, let me show you our angiograph today. Yes. Okay, this angio from AP aerial cranial. You can see the collateral from RAD to right side, and also collateral from diagonal to circumflex. Next one. And we see a middle
We don't see a moving image
RAD,
at the moment.
Severe stenosis. I will also check the calculate the QFR is 0.76.
Sorry, would you show us some moving pictures? Moving.
You can't see the moving picture?
Yeah, just a static image, right?
Okay, I will ask them to.
屏幕不对，屏幕是另外一个屏幕。
You want the
您现在能
moving
先
picture?
调这个吗？对。
Okay, that's
You
better.
can see that?
Yes, thank you.
Yes.
Great.
Okay, and we can see a severe stenosis at mid LCD. Calculated QFR is 0.76. Next one. And you can see the right coronary CTO. And the entry point is not very clear, and there's some calcification. And estimated around 20 millimeter long. Next. Next. And today we use the bi-radial approach to 7 French guiding catheter EBU and M+. And this is bilateral injection. We can see the anatomy very clear.
Yes.
Okay, I will stop here, and I want to listen to the suggestion and the comment from our panel.
Okay, any comments from the panel? You said there was a 90% LAD stenosis. Is that beyond the point where you would use the septal, or is it proximal to it?
Yeah, that is I think it's beyond septal.
Beyond,
we'll go back.
That's good.
Yeah. So we can, if we choose the retrograde, that will not impact the myocardium perfusion. You can see here. So we also calculate the syntax score for this patient. It's 22. And based on the guideline, if not a left main lesion, if syntax score is greater than 23, a CABG is another option. I want to listen to what is your opinion about this patient.
Yeah, who wants to put the case for an operation? Nobody.
Yeah, we should consider it.
We should consider it. Okay. But the LAD lesion looks very, very straightforward for angioplasty, so perhaps the benefit of bypass is lost because you'll just have vein grafts to the right in the circ. Everyone's sort of looking nonplussed.
Actually, the benefit of bypass surgery depends on the patency of LAD.
Yeah,
exactly. LAD. So as you mentioned, that the relatively the disease of LAD was far distal. And then Asian people, the lima relatively short. So it's a risk of a lima failure cannot do the bypass surgery with using lima. So I think in this case, if you can often with the PCI for RCA and circumflex, and why not just a medical therapy for LAD?
Mm-hmm. Okay. So do you want to show us where you've got to so far?
And another question is, the patient had 2 CTO lesions.
Mm-hmm.
circumflex and the RCA. And which one should be opened first? Do you have any suggestion?
I will choose the RCA because it's big and it's more significant. And there's, I suspect there's a stump, a small stump, although it's not very clear. But why we don't just try with some wire?
Yeah, I mean, you could say, well, the RCA is a bigger territory. It's a slightly more complicated CTO. Therefore, if you didn't succeed, you might, at that stage, say, okay, perhaps the patient has a bypass.
It could be successful because we can see that there's a stump. Probably we may try even in antigrade way, maybe, not sure, because you never know. Only you know while you try with the wire.
Yeah. I don't doubt that he'll get it open. I think, you know, the only issue for me was the fact that if the LAD had a stenosis proximally, then you might risk ischemia during your procedure if you treated the right first. Under those circumstances, probably treat the circumflex first.
So, okay, so maybe the circumflex CTO is more difficult compared to the RC in this case, because the circumflex CTO's entry point is no stump, and the distal position is a bifurcation site. If anterior approach failed, we lose another branch, the circumflex. So, and the circumflex region, as almost case, has a bent curve. It's slightly difficult compared to the other CTO region. And in this case, RC CTO region, the proximal site has a small stump and the micro channel is here. And the distal site and the island is here. And after island, there is a micro channel, as you can see. So maybe XTR or XTA can cause, maybe, fortunately. And physical collateral, suitable collateral channel from septal branch is here. So the lateral channel is one option, but anteriorly maybe success. You can get success.
Let's see where you're at.
Yes, agree. Actually, Doctor, we all know you. You are very experienced and excellent doctors. So what is your choice?
Okay, I will continue my story. And today we select RCA as our target lesion. And I have two reasons. One is circumflex CTO always torturous by nature. It's always difficult and always risky. Another reason is circumflex also have very good collateral from diagonal. So today I also found that there is maybe some channel, micro channel or loose tissue at RCA CTO. So I choose RCA as my today's target lesion. My plan is first go AWE. If it failed, and because the CTA showed some calcified lesion there, maybe it will fail. And then I also have retrograde option, many septal there. So I have another option to go retrograde. And this is my first attempt. I use XCR. As one of the panel said, use XCR to find the micro channel or loose tissue. And you can see it wanted to go a little bit into the CTO body, and I felt some resistance, and I found the wire tip deflected, and so I tried to pull it back and make it straight and adjust the direction, but it failed. Always go to the wrong direction. Next one. Next one. And after trying several minutes, and I upgrade the wire to Pilot 200. In this scenario, because the CTO segment is a little bit long, and also calcified tissue there, so if you use a penetration wire, sometimes it will make perforation. So I choose Pilot 200, it will be safe. And if it failed, I go retrograde immediately.
Okay.
And we are lucky today. It takes around 5 or 6 minutes. Next one. Just as I said, I try to make the wire tip straight. One, I think it's in the wrong way. I pull it back and adjust direction. Then,
Nice.
Next one. This is wrong way. Pull it back, and then adjust direction to get into the distal. And at this scenario, I can push the wire forward. If there is no deflection of wire tip, that means it's in the true lumen. If the wire tip deflected, it means in subinterior. You can see the wire tip is very straight. Next. Next. So it didn't take a very long time, only 15 minutes. So it's a lucky day. But the bad thing is I got another CTO lesion there. So my question now is, do you guys think I need to open another CTO in the same procedure or next time?
Great, great.
I guess it depends. I guess it will depend how much contrast you've used in the end, how long the whole procedure's taken, how much radiation.
Yeah, great.
So
see when you finish the first one.
Actually, Dr. Do, you don't use your hand. It's just a wire is going through by itself, right? Step by step is great. All right.
Yeah, nice.
Anyway.
Well, before the procedure, I think it's a relatively difficult case. So I start at 1 p.m., but it goes straight forward.
Yeah.
So let me show you the result of the right coronary. And can you put the iris on the screen?
Great.
Iris.
Very nice.
Completely reconstruction of artery.
Yeah.
It's good.
Very huge vessel.
How long does it take to pass the wire? It's just
10 minutes.
How long does it take? 1 hour or to pass the wire to the distal?
10 minutes, Dr. Park.
Here's some severe calcification.
We can see there is some calcified tissue in the CTO segment. And it is where I felt the wire tip deflected. So after check the iris, we know the where to put stent and how large the size of stent. We use the 3/0 cutting balloon and the 2/5 non-compelling balloon to pre-dilate the whole vessel.
Yeah.
Okay, stop here, and show the angio. And then we put the 3 stent, 3/0 by 38, and 3/5 by 2/3/0 by 33, and 3/5 by 28, and also do post dilatation. This is the final angio for right coronary, and because this procedure is very quick, so I think the contrast volume is very low, and less than 75 milliliter, and PCI procedure time is less than 40 minutes. Next one. So I think I need to try this circumflex CTO.
Yeah.
And you can see this. At first, I choose XTR gang, and I want to find the micro channel, but it failed. And then I choose the pilot 200, failed again, and it is much more difficult than RC. And then the next one.
We expect
and
the
because
CTO is very challenging because the distal end is also a bifurcation, and the stump is not clear, and seems the CTO is very old.
Yeah, agree. So because the antegrade wire can't catch the proximal cap, I use the double lumen catheter there, and under the support of double lumen catheter, I choose UB3, a little bit longer tip, and try to catch the proximal calf, and it failed. And then use the Bayer third, it failed again. And so I stopped here, and because the procedural time is around 1.5 hour and 90 minutes. So I stopped here. I want to listen to the panel's suggestion.
Yes.
Today I stop here, or go retrograde, or just treat LAD lesion.
Is there any financial concern?
I saw
We have
very
time
nice
limitation.
case, but instead of the double lumen catheter, we usually prefer the IVUS assistance osteum examination rather than the double lumen catheter. So in the next time, if we do again, probably we can have option of the IVUS guided catheterization.
What's the fluoroscopy time and the radiation exposure so far?
Total fluoro time is 47 minutes, and DAP is low, it's 184.
So he's a young guy, so is this also a concern as well?
Yeah.
And the technical base, so the circumflex lesion is at the LMT site, guide wire prolapsed during the cardiac motion. It means fine control for the guide wire for CTO lesion is very difficult to the in such situation. It means maybe we change the guide catheter, more large size, unplugged left 1.5 or 2 is better compared to in that situation. So maybe today to stop the procedure for the circumflex, I recommend. If we try to use the circumflex, more large size catheter is mandatory, I think, because guide wire go to the prolapse to the element at the LMT site.
Usually we don't fix the sacrum and RC CTO at the same time, because after we open RC CTO, some small tissue or debris will flow into the distal part. And the circumflex and RC have the same perfusion region. So even if I can successfully open the circumflex, maybe the distal perfusion will not very good. So I prefer to stop here today and show the angel again. Let the panel see the collateral. Next one. Well, we can see from diagonal there is a epicardial collateral. Maybe you use a SO3, and I think 70% successful rate to go retrograde. If we can use a SO3 across the collateral, and I think the success rate will be very high. But if it failed, I don't want to use a very strong penetration wire to do this circumflex CTO, because that's always make perforation.
Absolutely.
Are you tempted to put a microcatheter down into that diagonal just to do a tip injection and check that there is a good epicardial?
Okay, you want to do it now?
I'm just asking if you're tempted to do it. I mean, we don't see it. We see a hint of it, but maybe not completely. It would help, perhaps, in your planning.
Yes, I agree. So another thing is we also have noticed that mid to distal LAD is at the tortuous part. Any suggestion? Of course, it's easy to put a stent there, and I think there is some teaching point in this scenario. What type of stent will be proper or appropriate for this patient?
Now, everyone will have different thinkings. In this sort of situation, I can just say in my practice, after the RC CTO PCI, I will observe symptom. I will not touch the stress CTO. I will not touch this LED, because with this Z-shake LED, and you can see the movement of the vessel. No matter what understand you put in, the ISR weight is very high. Maybe the native vessel is the more doable, just medical treatment. And once the RSA was open, then there will be some retrograde supply to the LED. So the demand of the diesel LED will decrease.
Yes, I agree. And is there anybody want to use a drug-coated balloon here?
You could consider it, although it is rather tortuous, and your risk of dissection is probably reasonably high. But I wouldn't definitely do it now that you've just revascularized the whole right territory. That would compound the risks.
I don't have experience on using dB in this sort of situation. Maybe 1.5 dB. I will usually in this sort of situation, I will use very small dB, because once there's dissection, then you will force it to put on a stand.
But there is no 1.5 dB so far, I think, in the market. I think that's my case today. I'm sorry I didn't control time, but I have to do that because I can't wait that long.
No, not at all. It was a beautiful case, actually, and you described all the steps really nicely. It was just great skill that you managed to get through it so quickly when you did. So I think we'll probably say bye-bye to you, and thank you very much indeed for showing us that great case, and good luck with the rest of it when he comes back. Thank you very much.
Thank you again.
So anybody want to make any further comments about that case before we move on to the next bit of this session? Any thoughts? Nothing special. Okay, great. So let's move on. Gary Mintz is going to come. Thank you very much, Gary. Going to give us the featured lecture, which is imaging of coronary lipid-rich plaque.
Thank you so much. So the only real technology that's been validated for detecting lipid in the coronary plaque is near-infrared spectroscopy, and these are the seminal studies. The early studies of near-infrared spectroscopy predicting patient-level non-culprit MACE were 6, but these were relatively small studies. The first published large study was the LRP study in 9,000 patients, but not all 9,000 patients were followed for the entire 24 months. The predictors of non-culprit lesion MACE were a max LCBI more than 400, a plaque burden more than 70%, and a minimum lumen area less than 4 square millimeters. This is the patient-level cumulative non-culprit MACE comparing max LCBI more than 400 and less than 400, and you can see the event rate is roughly doubled. The same thing is true at a segmental level, although the event rate at a segmental level was about 4 to 4.5 times higher when the LCBI maximum over 4 millimeters was greater than 400. The second study was Prospect 2. It had an embedded randomized trial, treatment trial, which I will not discuss, but 900 patients with troponin-positive ACS had 3-vessel Neer's IVUS after successful PCI of the culprit lesions. The lesion-level predictors of non-culprit MACE were very similar to LRP, a max LCBI more than 325, which was the upper quartile, plaque burden more than 70%, minimum lumen area less than 4. And if we go through each of these, you can see a comparison of a lumen area less than 4 compared to more than 4 on a patient level. The event rate was 5 times higher. On a lesion level, also the event rate was 5 times higher. When we look at plaque burden more than 70%, the event rate was about 3 to 4 times higher on a patient level and about 10 to 11 times higher on a lesion level. And finally, looking at a max LCBI above and below 325, a doubling of the event rate in a patient level and about a 10-fold increase, or maybe a 7-fold increase on a lesion level. When we put the max LCBI and the plaque burden together, according to the 4 different possibilities, it was really only the group with a max LCBI more than 325 and a plaque burden more than 70% that had events. The others were actually quite modest at 4 years of follow-up. But it's important to note that this only represented 10% of the lesions, and that the positive predictive value was in fact quite low. I like this particular analysis because it looks at these parameters as a continuous variable. This is spline analysis, and you can see that the event rate takes off at about a plaque burden of 70% and a max LCBI of about 400. This is a clinical example, a patient with 3 lesions in the right coronary. This was the culprit that was stented. This was the proximal non-culprit that was not stented. This is the middle non-culprit that was not stented. And you can see there was a lot of lipid proximally, a max LCBI of almost 700, a lumen area of 3.8, a plaque burden of 80%, and at a relatively short follow-up, there is rapid progression, while the middle lesion, which looked only fibrotic by near-infrared spectroscopy, had no progression during that period of time. It is important, however, to note that while the MACE events were high, these mostly represented repeat revascularization or hospitalization for unstable angina. The rate of death and MI in both LRP and Prospect 2 was only about 1% per year. I'm not going to spend a lot of time talking about OCT, other than to say that when OCT is compared to near-infrared spectroscopy, the OCT findings are fairly consistent and fairly predictive. If you've got a max LCBI more than 400, you can see that roughly about half of them are TICVAs and another about 40% are thick calf fibroatheromas. But the CLIMA study was probably the cleanest natural history study. The CLIMA study looked at untreated LADs. They had 4 high-risk markers by OCT, an MLA less than 3.5, a fibrous cap thickness less than 75, a lipidic arc more than 180, and macrophage clusters, and the composite endpoint of cardiac death and target segment MI, another, was about 3.7% at follow-up. Here are 2 examples. The top example is a more stable lesion. The bottom example, this is a thin fibrous cap with some elements of macrophages. I don't know exactly remember what the lumen was, but you can see rapid progression over 1 year from 2014 to 2015. This is the data from this study. Again, pre-specified criteria are all 4 of these parameters. When you have all 4 of the parameters, the event rate is about 20% out about a year, compared to the absence of all 4 parameters, where the event rate was much lower. But again, similar to what I showed you in Prospect 2, the positive predictive value is relatively modest, 20%. The negative predictive value is almost 100%, and the prevalence of these lesions was only 3.6%. So even though these may be a predictive cluster that's very attractive, it is extraordinarily rare to see this. The combined study looked at FFR-negative lesions in diabetic patients, compared TICVAs to non-TICVAs by OCT, and the ones with TICVAs had a higher event rate compared to those without TICVAs. Again, substantiating OCT in this clinical setting, similar to near-infrared spectroscopy. I'd like to now focus the end of my talk on something that is rarely discussed at these meetings, which is the likelihood of distal embolization or periprocedural myocardial infarction during stent implantation. We looked at this histologically, and we compared by grayscale IVUS any attenuation and superficial and deep attenuation compared to the presence of fibroatheromas. And this is an example of, these are histologic studies. You can see attenuated plaque. This is not calcific plaque, but you did not penetrate to the adventitia here, here, or here. These represent fibroatheromas. This is a clinical example of a man with hypertension, diabetes, peripheral artery disease, presented with a new left bundle branch block and troponin. He had an ejection fraction of only 25%. Here's the angiogram. Long proximal LED lesion. And here's the IVUS image. I'm just going to skip ahead for the sake of time. And now we're going to get to the large septal perforator here. And now we're into the lesion. And you can see the large amount of attenuated plaque, both circumferentially and over the length. And the attenuation starts near to the lumen, consistent with this having a high likelihood of being, if you will, a vulnerable plaque. Predilation with a non-compliant balloon and an implantation of a 3-5 stent, and this is the angiographic result. The patient actually went into asystole. Fortunately, he had an Impella device in place. He was successfully resuscitated with giving vasopressors to correct the no reflow, and he eventually did okay. The Vampire trial looked at these patients in Japan, and they randomized the patients to distal protection versus no distal protection. And you can see that those who had distal protection had a lower rate of the no reflow phenomenon compared to those with conventional treatment. And at 1-year follow-up, MACE occurred 4 times higher in the distal, was 4 times higher in the conventional group compared to the distal protection group. There is a higher probability of distal embolization, and the common denominator is always the presence of a TICVA, whether detected by attenuated plaque grayscale IVUS, virtual histology, or integrated backscatter IVUS, OCT TICVA, or a large lipid core by NIRS. I just showed you attenuated plaque for a sense of variety. But the positive predictive value is actually quite low. There is a low probability of distal embolization predicted by but there's a high the positive predictive value of distal embolization is low, while the negative predictive value in the absence of these findings is very high. So to summarize, lipid-rich plaque is a bad actor. It does bad things in terms of natural history, and it does bad things in the cath lab in terms of distal embolization. Thank you for your attention.
Thank you very much indeed, Gary. The next speaker is Ik-Kyung Yang, vulnerable plaque to treat or not.
Thank you very much. Thank you, Dr. Park, for your kind invitation. Chairman, ladies and gentlemen. I believe this is a similar topic that Dr. Park gave a talk about. So this is my disclosure. So Einstein's definition of insanity is doing the same thing over and over again and expecting different results. So how is it related to vulnerable plaque research? So this is not what I said. This is what Steve Nissen said. It seems abundantly clear that the entire concept of vulnerable plaque is fundamentally flawed and results in an overly simplistic view of pathophysiology of underlying coronary events. To date, proponents of vulnerable plaque imaging have not conducted high-quality trials, and no imaging modality has demonstrated meaningful clinical benefit. After thousands of vulnerable plaque papers and more than 2 decades of research, we have little to show for this effort. A lot of things what Steve says, I don't agree, but this, to a certain degree, I do. So vulnerable plaque preconception. Human biology is not that simple, but this is preconception. Most ACS are triggered by plaque rupture, which is true. Most ruptures occur at thin cap fibroadenoma. They are associated. Identifying TICFAs confer high risk of ACS. Treating TICFA with stents prevent future ACS or sudden cardiac death. It's very, simplistic view of probably second-grade elementary school. So what is the definition of vulnerable plaque? And plaque that is prone to disruption, I like to use the word disruption because there are several underlying pathology, rupture or erosion, leading to occlusive thrombosis. There's a relatively new concept of healed plaque or layered plaque. So as you know, there's continuous plaque disruption, healing, leading to rapid progression of atherosclerosis, creating new layer. That's healed plaque or layered plaque. Oops. So I'm gonna try to convince you the vulnerable plaque facts. So atherosclerosis is a panvascular process. This has been a theme of my research lab for the past 2 decades. And plaque phenotype changes over time. It's a dynamic process that Dr. Mintz had published previously. 3/4 of plaque regress with medical therapy, and subclinical plaque disruption and healing, as I mentioned, contribute to plaque progression. And then finally, plaque erosion is responsible for 25 to 40, maybe up to 50% of ACS. So atherosclerosis is a panvascular process, and we have published this over decades ago. So we look at the plaque phenotype, but plaque at the non-culprit region, and compare the plaque phenotype between patients presented with ACS and non-ACS. So people with ACS at the non-culprit region, the plaques had higher level of vulnerability. If you look at TICFA prevalence, it's 44% in ACS and 6.9% in non-ACS, so stable angina and positive stress test. So we look at the comprehensive plaque mapping, patients presented with ACS or non-ACS, and look at the distribution of TICFA. So this is a panvascular process. The people presented with ACS have much higher level of panvascular inflammation, much higher level of TICFA in non-culprit region as well. So plaque phenotype changes over time, dynamic process. This is the work of Dr. Mintz and Kubo. So they did IVUS baseline and follow-up. About 75% of TICFA becomes less vulnerable plaque, either fibrous or TICFA. And reverse also happens. Stable plaque becomes unstable. So 3/4 of plaques regress with contemporary medical therapy, high-intensity statin therapy. Oops. Sorry. So we look at the plaque burden, PAB, at 3 time points, baseline, 6 months, and 12 months. And we look at the baseline plaque characteristics with OCT. So 3/4 of people, there is no progression, and in fact, with high-intensity statin therapy, there is regression of PAV. 30% increase, but about 10%, there's slow linear progression, gradual. And what really matters is it's 20% with rapid stepwise progression, either early on during the first 6 months or between 6 months and 12 months. That's what causes ACS, sudden cardiac death. So how rapidly does a plaque respond? This is a high-intensity statin, not quite 80, but 60, and this red, atorvastatin 20. So with the 60 milligrams of atorva, fibrous cap thickness doubles after 6 months and triples after 12 months. So there's rapid stabilization of vulnerable plaque. And as I mentioned, atherosclerosis is continuous plaque disruption and healing. And this layer plaque or healed plaque was found in 73% of autopsy cases. So one plaque disruption doesn't lead to ACS or sudden cardiac death. In fact, vast majority of plaque disruptions are silent. And plaque erosion is responsible. This is pooled data. About 1 out of 3 patients with ACS or STEMI, responsible underlying mechanism is plaque erosion. And with widespread of statin therapy, with better control of vascular inflammation, the landscape of ACS has been changing over the past 2-3 decades. So STEMI was the predominant type of acute MI, and now non-STEMI. And as you know, plaque erosion is frequent underlying mechanism of non-STEMI. So how about vulnerable plaque research so far? This is a landmark prospect study by Greg Stone. So total MACE was 11.6%, death 0, myocardial infarction 1%, as Dr. Mintz mentioned. The whole endpoint was driven by revascularization or rehospitalization due to recurrent angina. As an interventionist, recurrent angina is really not a big deal. You bring the patient to the cath lab and stent it. So how about the endpoint or predictors? So plaque burden, TICFA, it's not just simple plaque phenotype. And then MLA, closely related to plaque burden. If you look at the definition of VH-TICFA, it has to have plaque burden more than 40% and absence of visible fibrous cap. With VH, you cannot measure fibrous cap. That's the definition of. But one important component of VH-TICFA is plaque burden. So large plaque burden, small MLA, recurrent angina, no-brainer. This is a slide that I borrowed from Armin Zadet from Johns Hopkins. Risk of MI and death. That's the target associated with individual plaque in prospect study. TICFA, 0.4, intimal thickening, 0.3. So TICFA is not a lot more dangerous than intimal hyperplasia. So take-home message is potential risk of MI, combined STEMI and non-STEMI from VH-TICFA is 1%, which is similar to that from intimal thickening. And plaque burden, as opposed to plaque phenotype, is an important factor for development of recurrent ischemic events. So conclusion, the concept of vulnerable plaque needs to be revisited. Atherosclerosis is pan-vascular process with repetitive plaque disruption and healing. Over 75% of atherosclerotic plaques stabilized with contemporary medical therapy. Plaque erosion is responsible for 25 to 40% of ACS cases. So this is what I said a few years ago. The absence of natural history study, well-designed, large enough, and long follow-up, the invasive nature of current diagnostic modalities, whatever that is, OCT, BH, NIRs, IVUS, and effective contemporary medical therapy. And as you all know, there is no precursor for plaque erosion. There is no vulnerable plaque for future plaque erosion, contributing to at least 50% these days. Patients with ACS make vulnerable plaque research a major challenge. Thank you.
Thank you very much. 2 spectacular lectures. I'm not sure whether to be more confused, but I'm certainly more well informed. 2 really great lectures. Thank you ever so much. Any questions for either speaker from the panelists? No, fantastic. Well, thank you very much, everyone. That was a really, really great session. Thank you.